So, all right, what I'll be talking about is a little different situation. One is the iridoplasty, which is not such a popular technique, but one should learn. It is very, very simple. I think anybody can do it. The classic, once you have done a peripheral iridotomy, one must always dilate and see whether and do a gonioscopy. If the iris is still going on to the periphery and blocking the angle and your pressure rises, that means that probably you are dealing with a plateau iris, and that is a situation where you would have to do an iridoplasty. The other situations are opening a mixed angle, chronic angle closure, acute angle closure attack. So this is what happens, that you have done the peripheral iridotomy, and yet when you dilate, you find that the iris is just stretching out and covering the entire trabecular meshwork. So in this kind of a situation, you need to flatten out the peripheral iris. Despite an patent iridotomy, you will have a problem. So just don't leave at an iridotomy, and as we had discussed in the morning, it may be a case of multiple problems occurring at the same time. And it's not just that, it may be an angle, a pupillary block. There may be an associated peripheral iris block as well. So the trick is very simple. You take a large spot size, and the power is less. All you want to do is to stretch out the iris at the periphery, and be careful while you are doing it. You keep watching the pupil, that the pupil is not moving. But many a times the angle is so close that you can't stretch it open, and the pupil will move. Then you will know that it will not work in those situations. So you should abandon it. And you can use a lens, or you can do it without a lens. You have a larger size, around 200 to 500 micron. The power is less, around 0.3 watts. 0.1 second is the timing, and you do it around 1 millimeter away. But if it is too curved, you can actually start from over here, let it flatten out and go up into the depths. And many a times you can open up angles which don't look openable at all. And just to show you, you can go either direct, or you can do an indirect technique. This is where you don't use a contact lens, and you can just directly go in. And many situations where people are not amenable to putting the contact lens, you can just go ahead and do this directly. So this is the pre-gonioplasty, and this is the post-gonioplasty. The angle definitely opens up. The same thing shown on the anterior segment OCT, very clearly how this thing opens up. One of the most important things I think that everybody should remember, we had a VIP patient and landed up with an angle closure attack. You give mannitol, keep giving mannitol, all the other medication, nothing is working, and you are at your wit's end. And that is the time when I realized that Dr. Lam had given a paper in which even iridoplasty was as good as the medical therapy. And the iris is boggy, it is mid-dilated. You cannot do an iridotomy because it is mid-dilated, so it's all bogged up. So in this situation, if you do a peripheral iridoplasty, it really works well. And most of the attacks can be aborted by just doing a peripheral iridoplasty in these situations. So even many a times, if the block is at the lens, obviously you will ultimately remove the lens. But even in these situations, you can go ahead and do an iridoplasty, and at least you will get a temporary reprieve so that the pressure is down and you are operating on a soft eye. Again, a very common thing is nowadays we are seeing a lot of patients taking antidepressants, getting into an acute bilateral angle closure with high myopia and shallow ACs, which are classically because of drug induced. There, obviously, you stop the drug. After a few days, things will revert. You give atropine, peripheral iridotomy cannot be done. So if in these situations, again, it doesn't work, you can try your iridoplasty, and it does work sometimes. Now, some of the other unusual procedures, many a times we have blebs. We have done a trab, and the blebs keep spreading down. And this will result in hypotony. The patient is very uncomfortable. It's a cosmetic blemish. There could be macular edema because of the hypotony. So, obviously, you can give bleb sutures. This is one of the patients where we have done the bleb sutures, but you have to take the patient into the OT, and obviously, it's not a very easy job to do. So, what we thought was we paint it with gentian violet and do give large spots here to just shrink out the conjunctiva. And this really works wonders many a times. And this is just to show you, nothing really much there, but and Sometimes it can just paint it with gentian violet, put some anesthetic, paint it with gentian violet, and put large spot sizes. Be careful that it's not puncturing. It is just, and you are kind of making a barrier in that area. And once that barrier is done, it just shrinks down and prevents the further. So here you can see that this diffuse thing has just completely evaporated from here, and the bleb is just limited superiorly. The pressure goes up, the patient is much more happier, and we don't have to take the patient in the OT. Same thing happens with the overhanging blebs. You can do the same thing, paint it with gentian violet. Again, this causes a Dellen over here in the cornea, and you can be in serious trouble with that. Plus, the patient is very, very unhappy. The eyes can't close. Sometimes this staring look also comes over there. The same procedure will see how the flattening of the bleb is occurred, and Dellen and all are easily removed. And what Dr. Zuchi was talking about was multiple PIs. Yes, we had these problems that you do in a uveitic patient situation like this. The multiple PIs will keep closing because the inflammation keeps occurring. And many a times these are critical cases and you cannot operate. So this is the time then we developed this procedure for the first time in the world literature. And this is known as ND YAG laser synecholysis. So this is a phakic lens. You stretch out the iris as much as you can. It won't stretch much because there is a syneche. Use minimum power of YAG. Start inferiorly and go superior on either sides. And it will bleed. So you will have to tell the patient it has to be multiple sittings. But this was a patient of mine initially which came to us and who had this completely bound down pupil, one-eyed patient who had lost the other eye in some injury, uveitis. Patient was not ready for surgery, and that is when I thought that what should we do. So when we dilated this pupil with this kind of a procedure, the posterior subcapsular cataract was also bypassed, and the blockage of the this thing was also relieved because the aqueous can now flow from this area. So that really worked wonders for us, and you can see completely bound on pupil can completely open up like this. So this is something which you can easily do and will give very heartwarming results. Suturolysis, we all know that many a times if the releasable suture sometimes will break, you can go ahead and do a suturolysis using a Hoskins lens and use 1 watt of power and 50 micron, the minimum spot size. And you can blanch the conjunctiva with whatever phenylephrine or whatever solution you have so that it's whitish, and then you can press with this lens and go ahead and put the spot here, and after that you can just do a massage and the bleb forms nicely. The projecting suture, many a times these will leave projecting sutures, but you can again laser them down with a small power. I think we can leave that. Malignant glaucoma again is something which really gives you jitters, and if it is not working out by any other means, you can do a YAG laser hyaloidectomy. And what you can do is you can go through the peripheral areas if it's a pseudophakic, a phakic case, and if you can go through the capsule is fine. If you can't, you can choose a PI. Sometimes you have to go through the dialing hole as well. And what you're trying to do is first you do a posterior capsulotomy and then go deeper with the same kind of a lens. You can go in deeper and open the vitreous pockets which are blocking the aqueous, and the aqueous will flow anteriorly. So what is shallow like this will become deep like this. Again, sometimes what happens is that if there is a capsule which is all stuck up behind, so you need to do the capsulotomy right till the edge of the IOL. So if you do it till the edge of the IOL, the aqueous will flow out from the edge and come anteriorly. Because if you do a capsulotomy and do a hyaloidectomy, that still may not flow anteriorly. So many times you will have to do the capsulotomy right till the edge so that it can flow out. Now this was the case where it got trapped there, and once we made it all over here, it was able to flow out. So this is again a pre and a post case of malignant glaucoma. Thank you very much.